Think forward. Think Research Channel.
I want to thank all of you for coming out to spend some time this evening talking about chronic pain, and in particular talking about fibromyalgia. Now, it's helpful for me to get a sense in the audience, how many people in the audience are either experience fibromyalgia or have a loved one or somebody that they know that does. So fairly ubiquitous, and I think we're going to be seeing that fibromyalgia, that chronic pain, is an extraordinarily ubiquitous, extraordinarily common condition, and one that's been very, very difficult to treat. We think that we're on the cusp of some new medications, some new treatments for fibromyalgia that may have an impact on this very disabling disease. As was mentioned, I'm the chief of the pain management division here at Stanford. I've been here for almost 15 years or more. I spend a majority of my time doing research, trying to unlock the mysteries of chronic pain, in particular using various techniques that open up windows into your brain to help understand how pain fundamentally alters our nervous system, how we're beginning to believe that pain is ultimately a neurodegenerative condition, a central nervous system disease in and of its own right, and then trying to come up with new treatments to be able to reverse some of that. And I'll talk to you a little bit about that, specifically related to fibromyalgia, towards the end of this. Let me say that I get the vast majority of my current research information from National Public Radio. And so in a recent drive while coming into work, there was a survey on what Americans know about science. And I learned the following while driving into work, that by and large, Americans believe that H2O is hot water, CO2 is cold water. That water is composed of two gins. You may not know this. Oxygen and hydrogen. Oxygen being pure gin. Hydrogen is gin and water. Don't ask me what gin and tonic is. There are three kinds of blood vessels. You all learned this in school. Arteries, veins, caterpillars. Gonads are defined as a tribe of wandering desert people. My all-time favorite, to keep the milk from turning sour, keep it in the cow. I hope the science that I'm going to provide you over this next 45 minutes or so will be a little bit more on target. This is what I'd like to cover for you. I'd like you to get a better understanding of what fibromyalgia is. What are some of the mechanisms that cause fibromyalgia and cause it to be such a terrible disease in our society? I want to talk to you about some of the clinical features of fibromyalgia. How does it present? What is it that we see in our patients? And then let's get into the heart of some treatment options that we use for fibromyalgia and what are some of the results that we see for some of the treatment. And then I suggest at the end, again, we open it up for question and answer. And I'm happy to take on any questions that you want about fibromyalgia or chronic pain in general. Acute pain, chronic pain. I live for pain. So, I'm happy to have you hit me with your best questions at the end of this. So what is fibromyalgia? Well, it is defined as a chronic, widespread, painful condition that often involves a heightened sensitivity to pain. These patients, fibromyalgia patients, have an increased sensitivity to painful stimuli. We call that hyperalgesia in our world. They also have a heightened sensitivity to non-painful stimuli. Just simple touch can cause a sensation of pain. They also have a series of additional comorbid symptoms such as tenderness, sleep disturbances, they're fatigued, patients get morning stiffness, they get this cognitive impairment which people call fibrofog, and then there's these mood disorders, and we'll talk more about that in some degree of detail. What about the etiology? What about the causes of fibromyalgia? Well, there's a wide variety of causes that are being proposed for fibromyalgia. We are seeing some hereditable components to it. In other words, that we are passing it down to our children through our genes. We're seeing some very specific genetic mutations that may predispose patients to having fibromyalgia, and then also some very specific genes that encode certain enzymes in our system, one being this COMT, which encodes the breakdown of our catecholamines. It's the chemicals that are involved in our fight and flight system. that there's a defect there, there's changes there that may predispose people towards fibromyalgia. We're also seeing that environmental factors can play a role. So traditionally, I see time and time again when patients come in to see me in the clinic that they'll say, I can really pinpoint this back to when I had this motor vehicle accident, or I had this GI, viral syndrome, or there was a significant emotional trauma. This occurred after I was physically or sexually assaulted that I started to experience that. And so there's this common theme that there does seem to be some sort of an insult to the person that predisposes and triggers this. We also see concurrent fibromyalgia with these other rheumatologic conditions such as arthritis, autoimmune disorders, and then we also see a high preponderance of this with hypothyroidism. Extraordinarily prevalent, one of our more prevalent conditions in society, affecting anywhere from 2 to 5% of the U.S. adult population, affecting them predominantly between the ages of 35 and 60, some of our most productive years. And so it's hitting people right at their peak work years in their lives. We are seeing some significant gender differences. Women, overwhelmingly more prevalence of this compared to men. 5, 7 times as much female to male. We're going to talk about some other conditions as we go through this to try to draw some links between fibromyalgia and other conditions which also happen to impact women to a much greater extent. What are some of the mechanisms that are involved in this? Well, we believe that the central nervous system, the CNS, plays a significant role here, that it is ultimately a state of heightened sensitivity or heightened sensitization that may be explaining this increase in pain that subjects are having. There are some what we call excitatory neurotransmitters, glutamate and substance P. If you think about our nervous system, if you take a step back, everything is this balance between excitation and inhibition. Excitation and inhibition. And if you have too much of one, too much excitation, or too little of the other, inhibition, you end up with the experience of pain. And so substance P and glutamate happen to be excitatory neurotransmitters. They cause an increase in that excitatory aspect. And so you've got too much information coming into the brain. It leads to the experience of pain. And I'm going to show you some functional imaging data, some brain imaging data, which gives credence to this idea that fibromyalgia may ultimately be a central nervous system condition. So it helps to start off with some common language. We all have our own taxonomy. One of the biggest problems with doctors is that we have our own language that often can be very technical. There's a lot of jargon in it. And so it's helpful to define a few terms. I want to start off just by defining what pain is. We all think we know what pain is. We all have our own experience of pain. But let's talk about what the International Association for the Study of Pain has defined it as. The IASP defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. What do I mean by that? The takeaway points here is that pain is an unpleasant sensory and emotional experience. An experience. That defines pain as a subjective experience. It is whatever the patient says it is. We can't measure it, we can't touch it, we can't feel it. Each person owns their own pain, and there is no way to ultimately objectify it. That's to be distinguished from this concept that we usually think of pain, which is this idea of nociception, which is a fancy technical term. All it means are the electrochemical signals that occur when we have injury or trauma. And the problem is that we often want to draw a link between the amount of injury we have and the amount of pain we experience. And we've now learned that, in fact, they don't match up at all. And I spend a lot of my research describing this in detail and trying to understand the individual differences, why each and every one of you, if I give you all the same stimulus, you will all report a different pain score for it, each and every one of you. Historically, when we look back on how we've approached pain, painful conditions, pain syndromes, we tend to link these factors that cause the pain to the ultimate syndromes that got established. Let me give you some specific examples. All of you have probably had chickenpox. We've all had it as a kid. It's caused by a virus called the varicella zoster virus that lies dormant in all of us. As we get older, you can get an outbreak of chickenpox or an outbreak of this virus. It's called shingles. And it leads to a bad, nasty rash, oftentimes along our trunk, sometimes along our face. The vast majority of people, it heals up, but in some people, it stays there and you end up with something called postherpetic neuralgia. And what we've always done is we have always associated this viral outbreak with postherpetic neuralgia. We always associate the surgeon's scalpel with having surgery, with having surgical pain after that procedure. We associate pain in the joints to having osteo or rheumatoid arthritis. But the problem is that what's missing in this approach is that we've got these wonderful drugs and treatments for managing these etiologic factors. We've got antiviral agents that can take care of that virus during a shingles outbreak. We have the medications that'll deal with the original acute pain insult after surgery, and we've got drugs that can be used for rheumatoid and osteoarthritis, but we've still got millions of people suffering from uncontrolled pain. So what's missing in this? What's missing in this is a fundamental understanding of the pain mechanisms that are occurring as a consequence of this pain. In other words, we're beginning to appreciate that pain is a disease in and of its own right. That pain is causing fundamental alterations to the peripheral and central nervous system, as well as to the inflammatory system that persist, that stay there after the original injury, after the original insult has gone, and the tissues have healed up and are entirely normal. So what we're spending a lot of time is to better understand these pain mechanisms and try to reverse these changes, and I'm going to show you more about that. Now, pain all starts with a stimulus. It could be an incision, it could be a burn, it could be a trauma. It all has a common thread. It activates what we refer to as primary nociceptors. Now these nociceptors are transducers. They're transducers that lie in our skin, our soft tissues, and our deep tissues. And what a transducer does, it serves a singular purpose. It serves to convert one form of energy into another form of energy. And so it takes mechanical energy, chemical energy in the form of pH changes, it takes temperature changes, and it converts it into something called an action potential. And a transducer is something that's all very familiar to you. I'm talking on a microphone right now, which is converting the sound energy of my talking into an electrical signal that's transmitted along a wire and that over the airwaves. The only difference here is this transducer is converting it into an electrical signal that's transmitted up a nerve fiber in your body. And there are two basic nerve fibers that transmit these signals in your body. They're called A delta and they're C fibers. And one is responsible for your fast pain, your first pain, and the other one's responsible for your slow or your second pain. Let me give you an example for this. Have you all hit your thumb with a hammer before? Stepped off a curb, twisted your ankle? I want you to think back to that for just a moment. The last time you put your thumb on a tack the wrong way. You got that sharp jolt of pain that went right to your brain, right? Those are your A delta fibers that are very fast conducting, heading right up to your brain at about 10 meters a second. They just slam right up to your brain, and it causes a withdrawal reflex and an escape phenomenon. And then what happens? You have just enough time to think to yourself, oh darn, this is really going to hurt, right? When you feel there's a delay, you feel that hot burning sensation that comes over your thumb where you hit it with a hammer. Those are your C fibers that are kicking in a moment later that take about a second to a second and a half to make their way up to the brain because they transmit at about a meter per second, and it's about a meter to a meter and a half away. Now, these signals, these fibers, synapse in the posterior or the dorsal horn of our spinal cord, they cross over to the other side, they then head on up to the brain. This is the brain here, where we have what's called the thalamus. And the thalamus is like this big relay station in the brain. It's this grand central station. It serves to send these signals off to two major areas of our brain. Two major areas. The outside area of our brain, the lateral area of the brain, out here, which is where the somatosensory cortex resides. This is where we perceive the sensory aspect of pain. This is the location of it, the quality of it, the character, this is whether it's hot or cold or burning, and the intensity of it, all out here. Well, it turns out there's another major area of the brain that these signals get sent to, and that's this medial forebrain system here, the limbic forebrain system. This is our reptilian brain. This is where our basic emotions are processed and perceived. It's here where we experience the unpleasantness of pain, how much I don't like the pain, what is it going to take for me to get away from the pain. The suffering of pain is all perceived and processed right here in this part of the brain. And it turns out we're learning through neuroimaging studies and others that we are much more wired for that suffering, that emotional aspect of pain, than we are for the sensory aspect. Now, the story wouldn't be complete if we didn't have some way of controlling these signals that are getting sent up to our brain. And so what we've developed over thousands of years is these descending inhibitory systems. These systems, these blue pathways, they come down from the brain, they head down to the spinal cord, and what they do is they serve as a negative feedback system. They serve to, hey, tell the brain, tell the spinal cord, don't bother sending these signals up because they're not important. And it provides a very nice balance for you between excitation and inhibition. That inhibitory system, let me give you an example of that. You're probably not paying attention to the feel of the clothing on your back until I just mention it. Those are those descending inhibitory pathways telling your spinal cord, don't bother sending those signals up, they're not important. And what we've learned is that in chronic pain and in fibromyalgia, this system gets out of whack. It gets disrupted and disordered. And I'm going to talk with you more about that here in just a moment. Now, so this, folks, is your brain. This is your limbic system, right here. They have fancy terms like anterior cingulate, amygdala, prefrontal cortical regions, insular cortex. Just think of it as the emotional brain. It's your emotional brain. This is where your basic emotions are processed and perceived. This is your love. This is your fear. This is your anxiety, your hate, your tension, your anger, your stress. All of that is where it's generated and processed and perceived right there. And guess what? We're now learning that these same regions of the brain involved with our basic emotions are the same regions involved with the emotional aspect of pain. And so if you ever find yourself that your boss is angry with you, your spouse is all upset with you, and you're finding that your back's hurting more, your neck is feeling even a little bit more stiff, well, there's a neurophysiologic basis for it, because when you have an increase in those negative emotions, you're increasing, you're amplifying those same circuits involved with the emotional aspect of pain. They are directly linked to one another, which is why we spend a lot of time in our center trying to help people understand that fact and reduce some of those negative emotions. It's not just a psychological construct. We can now tell you exactly why and where it's occurring in the brain. Something else occurs in our nervous system in the face of pain. After an injury, it's this idea of neuroplasticity, this idea that our brain is changing, it's highly malleable, it's not fixed after a certain age, which is what I learned in medical school many years ago. Let me give you an example. Let's go back to that hand, and after an injury, let's say you get a cut on your hand. You all know what happens. Sharp jolt of brain goes to your brain, small delay, oh darn, really going to hurt. An hour later, you get inflammation, you get burning, you get swelling there, and you get an increase in the area that's painful. Then what happens? You go to bed, you wake up the next day, and now doesn't your whole hand feel stiff, aching, and sore? Think about the last time you twisted your ankle stepping off a curb. You wake up the next day, and now the whole foot and lower part of your leg is stiff, aching, and sore, right? That's what happens to all of us. What happened overnight is that our nervous system rewired. This area, the spinal cord and the brain, changed overnight, and it expanded the area that is perceived as painful. Now, why would it do that to us? Well, it serves a survival message for us, because it turns out that back in the cave people days, when we were out fighting the woolly mammoth and the saber-toothed tiger, when we got injured, it was in our best interest to go sit in a cave and let nature take its course and heal up that injured limb, rather than go out and fight the woolly mammoth or the saber-toothed tiger. Why? Because if you went out and fought them while you were injured, you got eaten, and you didn't get to pass your genes along. And so this presented as a very well-established survival signal. What happens in the normal situation is the injury heals, the neural switches turn off, they go back to normal. You get to go back and fight the woolly mammoth another day. If any of you are thinking to yourself, I wonder if in chronic pain and in fibromyalgia, maybe these neural switches are not turning off. Well, you're right on the money. We believe that that's what's going on in fibromyalgia and many of these other chronic pain conditions, is that you're getting an expansion of these areas that are now perceived as painful, and it's all being driven, a majority of it being driven by the central nervous system. And the question is, we're going to get to this a little later, is can we change some of this? We're learning more about this through the use of functional imaging, and so Rick Raisley did a really elegant study a few years ago in which he took fibromyalgia patients and he compared them against healthy controls, healthy people, and he applied a pressure stimulus to them. And what he found is that for the same pressure stimulus, fibromyalgia patients have a dramatic increase in brain activity. These are the red areas here in the brain. In all of the areas of the brain that have been found to be involved with the processing and perception of pain. And so it turned out that it was in very discrete areas of the brain that's involved with pain. Now what this suggests is that fibromyalgia may not be a rheumatologic condition, which is what we've always thought. Something involving the muscles, the ligaments, the tendons. It may ultimately be a central nervous system disease. And this is the direction that a lot of research is going in now, is that we believe that there is an enhanced sensitivity that's occurred in the brain. Think of it as you're turning up your stereo amplifier at home, to a higher number, to 10. So all the signals coming in now get amplified and sound louder. There was another fMRI study that came out recently in which they took patients with severe fibromyalgia and they had them do some cognitive tasks. And these cognitive tasks required a very rapid physical response to respond to it. And what they found is that the fibromyalgia patients ended up recruiting a significantly larger number of brain regions and an increase in activity in those brain regions, which suggests that they were having to work harder to do that task than the healthy people were. And this gets back to that concept of these cognitive issues that we discussed earlier, this fibrofog. Another way of looking at brain imaging is looking at the change in gray matter in your brain. And so what we'll often do is we'll take these standard MRI images of healthy people and we compare it against people who have chronic pain, in this case fibromyalgia. This was a nice study that Kathy Bushnell's group did. And what she found is that fibromyalgia patients have premature atrophy, premature aging of the brain in specific regions of the brain involved with the emotional aspect of pain, the thinking aspect of pain and our executive functioning. These are some of the frontal regions of our brain. And then the perihippocampal gyrus, which is involved with our stress response, suggesting that these areas of the brain are atrophying prematurely, and it may be playing a significant role in why these patients develop fibromyalgia and why it gets maintained. And maybe we can talk about more in the Q&A session about what this really means and how to interpret this. And it turns out the longer you have the fibromyalgia, the more brain atrophy you end up getting. We've done some similar studies in neuropathic pain and find the same exact thing. If you had nerve injury pain that lasts for a long period of time, you've got premature shrinking of your brain, and it correlates well with both the intensity of the pain as well as how long you have it. So in summary, the recent data suggests that the central nervous system is playing a dramatic role, a significant role in fibromyalgia, that central sensitization, this idea of this increased sensitivity in the CNS, is coming out as a predominant model for fibromyalgia. This is being supported by fMRI data as well as structural imaging data. And so the key is maybe focusing on agents that actually impact the central nervous system. And as I'm going to tell you in just a little while, if you think about the agents that we use to treat fibromyalgia, all of them work in the central nervous system, and very few, if any, of the agents that work out here in the periphery have been shown to work on fibromyalgia. So what are some of the clinical features and how do we go about diagnosing fibromyalgia? Well, as we've talked about before, it's a widespread painful condition. It's associated with sleep disturbances, fatigue, morning stiffness. Patients are more likely to have also comorbidities, coexisting conditions such as painful neuropathies and circulatory disorders. There's a number of different criteria that have been used to diagnose fibromyalgia. And some of these symptoms overlap with many other conditions like irritable bowel syndrome, major depression, chronic fatigue syndrome, systemic lupus, rheumatoid arthritis, osteoarthritis, and Lyme disease. And we need to be able to distinguish these when we think about fibromyalgia. Now, widespread pain tends to be the sine qua non of fibromyalgia. Patients have pain in multiple parts of their body, at least 3 out of 4 limbs above and below the diaphragm with, as I'll describe, these 11 out of 18 tender points that get bantered around, sleep disturbances, fatigue, and early morning stiffness, and this tenderness, this presence of the tender points I mentioned. Let's just go into some of the details of this. Widespread pain, whole body pain is what distinguishes fibromyalgia. These patients hurt all over. They hurt on most of the parts of their body. And sleep disturbances play a significant role. So there's this concept of non-restorative sleep. So in healthy people, when you go to bed and you sleep 8 hours a night, you wake up, you feel rested the next morning. Fibromyalgia patients don't feel rested. They don't. And there's been studies on this looking at EEG correlates. And what they find is there's this concept of alpha wave intrusion. Alpha waves are part of our EEG. It's a spectrum, a frequency of our EEGs that is present predominantly during awake alertness. So many of you are engaging in alpha wave rhythms right now, as opposed to some of the slower waves and some of the slower waves involved with some of our deep sleep. So when patients are in a sleep state, what they're finding is they're getting these bursts of these alpha waves that are intruding, that are preventing them from getting a good and restful, restorative night's sleep. And this has been well established for some time. There's actually something else. There was another recent study that came out of Jennifer Haythorne-Waite's group out of Johns Hopkins, demonstrating this link between sleep and pain. That's really fascinating and getting a lot of research interest right now. What they did is they took subjects. They took subjects in 3 separate groups. One group got to sleep as much as they wanted, and everybody wants to sign up for that one, right? And then there was another group where they only got 5 hours a night of sleep, but they got continuous 5 hours a night of sleep. And then there was another group that got 5 hours a night of sleep, but it was over an extended period of time, and what they do is they go in and wake them up intermittently throughout the night. It's like our medical students and our residents who are on call all the time being woken up. And if any of you have ever pulled an all-nighter or been woken up, you just feel terrible the next day. Well, what did they find in these groups when they tested pain tolerances? Well, the people who slept all night long had no change. They did great. The people who slept only 5 hours, turns out they were normal as well. But the people who were woken up intermittently throughout the night, they had dramatic abnormalities in their pain thresholds and their pain tolerances. Something had happened in their brain overnight from missing that one night of restful sleep. Sleep plays an extraordinarily important role for all of us, and we're just beginning to understand what it's doing in its relationship to pain. We're going to be seeing more and more research about this as the years go by. Mood disorders. We tend to think, unfortunately, fibromyalgia patients get a bum rap because, they're often told they're hypochondriacs or this is just anxiety or depression, and it just does a terrible disservice to the patients. We find that mood disorders actually occur at probably a lower rate than many of the other chronic pain conditions. In my low back pain patients that I see at the Stanford Pain Center, I'd say 60 to 75% of those meet a diagnosis for depression. I would say it's a much lower number for our fibromyalgia patients. So they're not always associated with a high percentage of mood disorders. There's been studies on imaging looking at some of the mood disorders in fibromyalgia patients. And what we find is, this was a newer study that Rick did, that they find that if you apply those pressure stimuli and compare fibromyalgia, these were all groups here, all fibromyalgia groups, what they found is an increase in sensitivity to that pressure stimuli in these areas of the brain involved with the processing of pain. If you just look at the brains of people who have depression and fibromyalgia, you see the same pattern, but you also see an additional pattern. That is an increase in activity in an area of the brain called the posterior insular cortex, as well as an area called the hippocampus, as well as the amygdala, which is this area right here. This is an area involved in major depression. And so it gives credence to this idea that depression and pain are overlapping. They share similar networks. But you really have to treat them both if you're going to make an impact. You can't simply treat the pain and expect the depression to go away. You can't simply treat the depression and expect the pain to go away. Education and appropriate diagnosis plays a crucial role for patients with fibromyalgia. We find that if we actually can help patients to understand what they have and what's going on with it, why they're experiencing what they're experiencing, you see a significant improvement in patient health satisfaction from baseline to after this education. Just the very idea of having validation, letting them know it's not just, all made up. It's not just something that's due to stress, that it's a real condition, and helping them to understand what it's all about and what they can do about it leads to a significant improvement in healthcare satisfaction. So let's talk now about the way of diagnosing this. Many of you may have heard of this American College of Rheumatology diagnostic criteria. It came out about 18 years ago. It was meant as a research criteria. It was not meant to diagnose necessarily individual patients. But what it involves is that patients have to have at least 3 months of widespread bodily pain, exhibit tender points in 11 out of 18 of these different points. And it's to a pressure that it's about the right amount of pressure where if you pressed up with your thumbnail against somebody or against yourself, it would blanch your thumbnail. That's about how much pressure we have to give to those areas. And we find that if you have those 11 out of 18 tender points, if you've got widespread bodily pain, 3 out of 4 extremities above and below the diaphragm, and you exclude other conditions, you meet the diagnostic criteria for fibromyalgia. Now, the Canadians took this to another level. What they did is they added in some additional symptoms, sleep disturbances and fatigue, into their diagnostic criteria, and it added a somewhat richer way of diagnosing fibromyalgia. We predominantly use the ACR criteria here at Stanford. So the idea is ultimately to do an appropriate history and physical examination on a patient. We need to rule out other conditions, so we can't just jump to fibromyalgia as the cause of a patient's pain. And then we have to confirm these presence of the tender points, and with that we can ultimately say, you've got fibromyalgia. Now the key is, how do we go about managing it? How do we make an impact on patients' lives who are suffering from fibromyalgia? So we have to do this using a variety of different tools and techniques. So at Stanford and at other large academic centers, we approach it using a multidisciplinary treatment approach. In other words, we apply these 4 legs to a table, if you will, that involve a pharmacologic approach, a psychological or behavioral approach, a physical and occupational therapy approach, and a procedural approach. And this all should be done in an integrated manner. That means teams of people working together, coming together, each with their own areas of expertise towards the treatment and management of patients with chronic pain. The Stanford Pain Center, we are the major tertiary comprehensive pain center here in this part of the state and country. We see over 8,000 patients a year. We've got, it says 8 clinical pain faculty. It's actually closer to 9 to 10, boarded in a variety of different specialties, all working under one roof. We train a number of clinical pain fellows. We have also onboard clinical pain psychologists that play a significant role in what we do, as well as our nurses who are trained specifically in pain management and know how to help manage these patients. It is because of this multidisciplinary approach that it was, as mentioned, we were fortunate enough to receive an American Pain Society Center of Excellence Award just several months ago, which recognized this year 6 centers throughout the country that have received this award. A total of 12 have been awarded in total. And so we're very proud to be able to have this. What's beautiful about this award is it was given not to one single person, but it was given to the whole team approach, the whole way of managing pain. And so we're very grateful and proud of that recognition. Now let's get back to how do we go about managing patients with chronic pain, fibromyalgia in particular. Well, we apply both these non-pharmacologic as well as pharmacologic approaches. We apply things like aerobic exercise, cognitive behavioral therapy, patient education, strength training, acupuncture, biofeedback, hypnotherapy. I'm going to talk about all these in some degree of detail. And then we use a variety of different medications here. And what you're going to see in pain management in general and fibromyalgia in particular is that we steal from everybody, okay? We steal from everybody. We take from the psychiatrists their antidepressants. We take the anticonvulsants from the neurologists. We also use antiarrhythmics, cardiac arrhythmia drugs from the cardiologists. And we apply it all to patients with fibromyalgia and chronic pain, and we often find that they work better for pain than for the original condition upon which they were prescribed. This is a very complicated slide. Don't bother memorizing it. Let me just give you the 30,000-foot view. This is how we tend to think about applying these medications in somebody with chronic pain and fibromyalgia. We try to identify where the source of the dysfunction in the nervous system is occurring, and then we have a number of different medications in our toolbox that we can use that attack these signals at different parts in these pain processing systems. And so what's nice about this is that in the year 2008, we have a much larger number of medications than we can use than when I got into this field about 10 years ago, when it was much more limited. And just looking at a few of these, I mentioned the antidepressants, and so this is also a busy slide. The antidepressants are medications that are used for mood disorders to treat depression. We find that in some of the antidepressants, some of these older drugs, these what we refer to as tricyclic antidepressants, things like Elavil or amitriptyline, disipramine, imipramine, old drugs, they can be very effective for the treatment of fibromyalgia. It turns out they work in different regions of the brain for pain than they do for depression. They work predominantly, we believe, on those descending inhibitory pathways. And so we believe that in part, fibromyalgia is also a dysfunction of the inhibitory system. And I'm going to talk with you more about that in just a moment. These drugs tend to normalize that. Similarly, a new class of medications has come out called the serotonin and norepinephrine reuptake inhibitors. These are newer antidepressant drugs. These are drugs like Effexor or venlafaxine, duloxetine or Cymbalta is the trade name, and then also milnacipran. Milnacipran is only available in Europe, by the way. They're trying to get FDA approval in the United States. We're not going to talk about this. Let's talk briefly about duloxetine. Duloxetine received FDA approval for fibromyalgia in June of this year, so it's just been FDA approved for it. And in large-scale clinical trials, they did show a significant improvement in fibromyalgia symptoms while patients were on this drug. We're studying this drug right now at Stanford on low back pain, looking at where does it actually work in the brain and trying to understand who is most likely to respond to this particular drug. So we found it to be a very effective drug. It does have side effects associated with it. All the drugs we have, almost all the drugs, I'll talk to you in just a moment about a drug that we haven't been seeing much side effects, but the vast majority of them have some degree of side effects. With this particular drug that's FDA approved for fibromyalgia, its GI upset usually lasts for about a week, and then it tends to clear up. You can get a little bit of sedation, a little bit of cognitive impairment. Most of these tend to clear up as well. The analgesics, we tend to think of these are the opioids, narcotic agents. And they have been studied in fibromyalgia, the most common ones being tramadol. It's a very weak opioid, but other agents have been looked at as well. Highly controversial subject in the area of the management of fibromyalgia because of concerns of addiction and abuse. We honestly don't see much in the way of addiction and abuse, but we're not convinced that these drugs have a long-term role in the management of fibromyalgia. But in some of the studies, they have shown some improvement. And some, yes, they've shown improvement, and others, they've shown none. Unfortunately, you solve one problem with an opioid, you end up introducing another. And so these agents, unfortunately, come with some baggage. And so with the opioids, the narcotics, you get cognitive sedation, you get urinary retention, you get respiratory depression. We're learning now with long-term opioids, you can also get endocrine abnormalities. In men, you get hypogonadism, which means your testosterone level plummets, absolutely plummets. And I got to tell you, women, you're not off the hook either, because we find that your hormone levels also take a big hit when you're on these opioids for long periods of time. It leads to decreases in sexual libido as well as energy, and may even lead to increased pain. We've also found, we're studying this also at Stanford, that long-term use of opioids can also lead to this condition we call opioid-induced hyperalgesia, which means that the opioids themselves over a period of time can wind up your central nervous system so that you end up feeling more pain instead of less. It's kind of unfortunate. The very medications we're taking to help with the pain may actually be making it worse. I told you that we steal from the neurologists, so we take their anti-seizure medications. The most common ones that have been studied are gabapentin and another drug, pregabalin. Pregabalin is a drug that received FDA approval about a year ago, and it's been used effectively for fibromyalgia. It's also FDA approved for postherpetic neuralgia and diabetic neuropathic pain. And they have shown in large-scale numbers that there is significant improvement with this drug. Let's talk about some of the non-pharmacologic therapies. Patient education. This is an area we spend a huge amount of time on in our patients with fibromyalgia, helping them to understand what's actually going on, why they're experiencing what they're experiencing, why it's very real and it's not made up, and they're not being a hypochondriac, and that there are things that can be used that can be helpful. Aerobic exercise, mild aerobic exercise, not getting out there on a heavy Stairmaster or doing step aerobics, but doing mild aerobic exercise has been shown to have significant improvement in patients with fibromyalgia. The problem with exercise and fibromyalgia is the following. If any of us, if any people, any healthy people, go out and run several miles or you go work out, you get that runner's high. You know what I mean? That you feel good after working out. Fibromyalgia patients don't. They don't feel good after working out. They actually feel worse. Part of this may be due to that dysfunction in those descending inhibitory systems. Those descending inhibitory systems that are not working properly in fibromyalgia patients, such that those systems which, when we're working out, when healthy people are working out, we get those systems cranked up and we feel pretty good. In fibromyalgia patients, they don't. Let me give you an example here of the way we're studying this from a research standpoint. If any of you ever had pain in your shoulder, pain in your elbow, pain in your knee, and you go and you tell your buddy, hey, you know what, my shoulder's bothering me, it's really hurting. And they say, oh, hey, I've got a fix for that. And you say, what? What's that? And they go and they stomp on your foot, right? And you say, why did you do that? Why did you do that? And they say, well, doesn't your shoulder feel better? Right? We do this as kids. We do this as kids, but you know what? It actually works. It actually works. If you go stomp on somebody's foot while they have pain in their shoulder, they'll experience less pain in their shoulder. And this has been studied from an experimental standpoint. It's called descending noxious inhibitory control, DNIC. It's a fancy term. It's called DNIC. That means that when you cause pain in another part of the body, it actually reduces the pain in the first part of your body. And that's through activation of those descending inhibitory systems. It's cranking them up when you go step on somebody's foot. In everybody, except for people with fibromyalgia. It doesn't work. It doesn't work. It's particularly women with fibromyalgia. They continue to feel pain. And so if you know somebody with fibromyalgia and they've got pain in their shoulder, don't go stomp on their foot because they will not feel better in their shoulder. Cognitive behavioral therapy, also very effective, has been shown to be effective for fibromyalgia. What is cognitive behavioral therapy? Cognitive behavioral therapy boils down to this basic concept of how you feel is what you think. How you feel is what you think. And that means that the frontal regions of our brain, remember those front regions of the brain I was showing you? Turns out they have direct connections to that limbic emotional brain. That limbic emotional brain. And that if we can learn to control our thoughts and about how we feel, how we think about pain, how we approach pain, we end up experiencing less pain. We end up having a lot less of this wind-up, this central sensitivity, and a lot less of this emotional aspect of pain. Now, I'm giving some very gross oversimplifications of this, but that's the basic tenet of it. It's components of reframing how you're approaching pain, thinking of it maybe less in a, not so much of a sinister manner, but understanding where it's coming from. And it's that knowledge that is often very empowering in cognitive behavioral therapy, and it needs to be done through a skilled pain psychologists, and these are people that we have on staff at Stanford who are very good with helping people to learn these new skills. And so I was asked specifically to comment on maybe some of the novel things that we're doing here at Stanford that set us apart. And so we just finished up this study on a drug that's called naltrexone. Naltrexone. And naltrexone is an interesting agent, because I'm going to talk to you about in just a moment. It's an opioid blocker. It's an opioid blocker, but using it at low doses, it actually has an impact on glial cells. Now, what in the world are glial cells? Well, glial cells, microglia, happen to be these immune and support cells that are in our nervous system. They prop up our nervous system, and they're also, as we've learned now, major regulatory cells within our central nervous system. They're also key players in the immune system that resides within our central nervous system. And so they get heavily activated. They get heavily activated during an infection and during cell damage. Normally, these microglia, these glial cells, are in a resting state, and they're just kind of hanging out, looking around for problems to occur. What happens is that when they get activated, they end up pulling in their branches, they become mobile, and they take off to go attack where the problem is. They also end up producing a number of chemical factors within the brain, as well as the spinal cord. These chemical factors can ultimately increase pain sensitivity and lead to something that we refer to as this sickness or illness syndrome. So we've all had colds, we've all had viral syndromes, we've all also had injuries. And what happens after a cold or after an injury? Well, you get a release, you get this activation of these microglia, they release all these chemical mediators, and they put in play this illness syndrome. And this illness syndrome is what makes us all want to go lie on the couch with the covers over us and, find somebody who's willing to bring us the hot chocolate for us to drink, and take care of us. These are illness behaviors. They're hardwired and programmed into each and every one of us. My 11-year-old son plays it up well every time he gets a cold. And it's a highly adaptive, set of behaviors. But, you get over the viral illness and, he goes back to school and it's business as usual. What we believe is happening in chronic pain is that these glial cells are not going back to a normal state. And they're continuing to release these mediators. They're continuing to stay in this role in which these sickness behaviors continue to be prevalent. And we believe, as I said, in fibromyalgia, that ultimately these cells are stuck in this on condition. And so you have a state where you have the central sensitization, and then you also have these glial cells that are also stuck on, continuing to release these mediators, continuing to cause these illness behaviors, ultimately leading to an increase in pain sensitivity and fatigue. So let's talk about naltrexone. Naltrexone is a drug that works on opioid receptors. It blocks them, and it blocks them cold. It just shuts them down. It shuts them down so that narcotics don't work. So if you take a naltrexone and you take a big narcotic, it'll have no effect on you at all. And this is a drug that's been used for instance, for alcohol addiction and also opioid addiction. That's where it's predominantly used for. Typically at doses that are about 50 milligrams, 50 milligrams. It turns out, though, particularly at lower doses, that we find that it actually blocks a specific receptor on the microglia. And so it has this effect where it prevents the release of these inflammatory mediators, these pro-inflammatory agents that the microglia ultimately are involved with. And so the thought is that by using this low-dose naltrexone, and we're using 4.5 milligrams, it's an odd dose, but we and others have done some dose finding, given once a day. This is 10 times less than the usual dose. The thought is maybe this will have an impact on a patient's pain with fibromyalgia. So this is a study that Jared Younger was a senior postdoc in my lab. He's now an instructor in the lab, and he's been running this study and just doing an absolutely fabulous job with this and recruiting patients with fibromyalgia and running them through it and monitoring them. And the way that we've been doing this is we monitor patients on a daily basis with a little Palm Pilot that beeps at you every day and asks you to fill out how much pain you're having, what's your mood like, what's your function like. And what we find is that during the baseline phase, these people are coming in with about 60 out of 100, or what would be equivalent to 6 out of 10 pain. Most people would think pretty moderate to high pain. And then during the placebo, this is during the placebo phase here, because we do this in a controlled manner where they also get a sugar pill. And then we start the low-dose naltrexone. And what we're finding is, in a pretty rapid period of time, within a couple weeks, people are having a really dramatic improvement in their pain symptoms. And we found that there was an average of over 50% reduction of pain in these patients, and that ultimately 7 out of the 10 patients were very positive responders. 3 of them, quite frankly, had no response at all. They just didn't get any better, but 7 of them really did have a profound benefit. And we washed the drug out, there was a return of their pain back towards baseline. We also showed a significant improvement in their fatigue, anxiety, but I also want to focus on sleep. Sleep was a significant factor here in all of these patients. They had dramatic impairment in sleep, and within generally a week, patients were describing a real improvement with their with restorative sleep. So, 2 things I want to leave you with on this study, and before I close out. 1, you should always be cautious. If anybody gets up in front of you and they talk about a new drug, and they haven't shown that it's been published and gone through peer-reviewed through the scientific community. And I didn't do that. This study has not been published yet. We are just writing it up now and putting it in. And so I want you to view this with some degree of skepticism. This was a small trial, small number of patients. I'm not trying to pitch snake oil here. I think that we've got some promising results. We're now recruiting for a larger and longer scale trial. And this is my pitch to you. If you or any of your friends or family have fibromyalgia and you're interested in being involved in a study, we cover the cost of the drug and all the monitoring of it. You might come to our website, which is snapple.stanford.edu/LDN. Or you can email me at Smackey, S-M-A-C-K-E-Y, at stanford.edu. We'd be happy to evaluate you for the trial. We've got a long way to go before this is a drug that's going to be used for global widespread usage. It's a drug that's probably never going to be carried by a large-scale drug company because it's a generic drug. It's been out there for decades, and so you're not going to find a big drug company pitching this. The nice thing is it's just dirt cheap. It's just dirt cheap. And so it'll be ultimately, if we find that it does work, it'll be something that'll be a nice, affordable solution for people. But again, the onus is on us to prove that it actually does work. And we've got a long way to go. Well, let me close out on one last slide here. And let me just say that Congress has only dedicated 2 decades to medicine in its entire history. The 90s were the decade of the brain in which we unlocked wonderful mysteries of how the brain functions and developed wonderful techniques and tools for opening windows into the brain. We're currently living in the decade of pain control and pain research, and we're all hoping that by the end of this decade that we'll have made a much bigger impact on our patients suffering from pain as well as its impact on society. So with that, thank you again for coming out tonight. I'd be happy to answer any questions about fibromyalgia, about chronic pain. Again, I live for pain. I'm very interested in the topic and happy to answer your questions. Thank you. It's basically a historical concept. And so the early pain clinics were formed by John Bonica up at the University of Washington at Seattle. He trained some of the earliest pain physicians who were anesthesiologists. And then they went out and built other pain centers. And a lot of the early work in pain was interventional work. It was procedural work. And so anesthesiologists are very good. We're good with procedures and sticking needles in people, and we love doing it. And we're good with the pharmacology, the drugs. But what we've now found as the field has matured is that we need to bring in other specialties. Other specialties bring in unique areas of expertise. The neurologists bring in their expertise, physiatry, physical medicine and rehab theirs, psychiatry theirs, and a host of other specialties as well. We find that by working together we get the best results with patients. A relationship with Lyme disease and this whole body pain, and if people have Lyme disease and it's well characterized, it can cause all these signs and symptoms, and so the treatment should be aimed at trying to treat the Lyme disease. For people who've had appropriately treated Lyme disease and the symptoms still persist, then we would say that they have fibromyalgia if they meet all the rest of those criteria. Let me just also make a point. This is one that, if I can expand on this for just a moment. Fibromyalgia shares characteristics with a large number of other conditions that we are now putting under this umbrella of central sensitivity conditions, central sensitivity syndromes. Irritable bowel syndrome, you folks familiar with that? Pain in the abdomen. Interstitial cystitis. This is painful bladder symptoms. Temporomandibular disorders, painful jaw and the joint here. Temporomandibular disorders, tension headaches. Complex regional pain syndrome, which is a neuropathic pain condition affecting the extremities. All of these share very common characteristics with these painful body conditions, long-standing, very high female to male preponderance. Almost, vast majority of them are women. Sleep disturbances, GI disturbances, mood disturbances, chemical sensitivity syndrome, another one. Chronic fatigue syndrome being another. Again, they're all being put under this umbrella of central sensitivity syndromes. And we think that they may share common etiologies, common mechanisms within the central nervous system and the immune system. And you're finding, I'm on some NIH panels right now in which they're starting to look at these diseases from that perspective, because the way that we've been approaching these diseases in the past hasn't been working. And so you're going to see more and more of these diseases get studied together. We just are on a grant now that's looking at painful bladder symptoms and interstitial cystitis and making comparisons against fibromyalgia, because we think that they share tremendous overlap. So multiple soft tissue damage is, it's not a term that I have a lot of familiarity with, and I think that what they're referring to is somebody who has perhaps like myofascial pain syndrome, the soft tissue damage being their muscles. Fibromyalgia used to carry a lot of other terms, fibrositis, myositis. There was a lot of other terms that they used to use with fibromyalgia before they consolidated it into this term fibromyalgia, although now we're finding that maybe that's not such the best term, because it tends to suggest that the problem lies in the soft tissue, in the muscles, tendons, joints, and ligaments. And in fact, with appropriate diagnosis and ruling out of those types of conditions, it seems like it's more of a central nervous system condition. And I'm not suggesting that your family member has that, but perhaps that's a term they were using to describe fibromyalgia. So low-level lasers have shown it's mixed results. There's a lot of open-label studies that show improvements with low-level lasers. There's not a lot of what we call the gold standard in medicine, which is randomized controlled double-blind trials. And this is the problem, is that in our specialty, placebo has such a huge impact. Placebo is a very real phenomenon. Very real phenomenon. Don't let anybody tell you that it's made up or it's not something real. Because we've done neuroimaging studies, other people have done it. It really impacts the brain. And the problem is with devices and with medications is separating out the real placebo effect from the actual pharmacologic action of a drug or a device in this case. And so we believe, at least in large part, there's a lot of placebo to low-level laser. There may also be some additional activity. We really need better studies to be able to demonstrate that. A couple things to that point. One, we don't yet know what that brain shrinkage represents. We don't know if the brain shrinkage represents actual loss of neurons, actual neural tissue loss, or whether it represents something else. We have only looked at, we being the research community, not our group, has looked at patients with depression. And what they've done is, after patients have passed away, they have done tissue sampling. And what they find is it wasn't loss of the neurons that led to those MRI changes in depression. It was loss of glia. It was those supporting structures, the supporting cells that tended to decrease. We don't know if that occurs in pain. So first, we don't know what it really means. But we know that there's something going on there. The second thing is, we don't know about the chicken and the egg. In other words, is it that it's the fibromyalgia that causes the brain to shrink in those certain areas? Or is it that those patients with fibromyalgia already had the shrunken areas of the brain and it predisposed them to getting fibromyalgia? Do you understand what I'm saying? There's this concept of, we always have to be careful in interpreting data, this difference between correlation, something that's associated, one thing to another, and causation. This caused this. And so I'm not suggesting, I don't want to leave you with the impression that fibromyalgia causes brain shrinking, just that it seems to be associated with these changes. Now, what we're trying to do is to find out, can we reverse these changes? Can we make a difference? That's what our group is studying right now, looking at some treatments to see whether placebo changes this and then also whether the active agent. We didn't see any. We didn't see any significant side effects with the low-dose naltrexone. It was remarkable. It was remarkable. Now remember, folks, please, don't go out and think that this is a drug that's going to, cure fibromyalgia or everything. In a small group of patients that we studied, it was extraordinarily well tolerated. There were no significant side effects. We were very pleased with the results. We need to look at this in a larger scale. In larger doses, used for alcohol addiction, and used for drug addiction, there has been side effects associated with it, but we haven't seen it when we're using it 10 times smaller in dose. It's been relatively side effect free. Guaifenesin is the active ingredient in cough syrup, Vicks 44. And at larger doses, it works through what's referred to as NMDA receptors and blocks it. And NMDA receptors are part of the excitatory nervous system that passes on signals through. There is some tantalizing evidence that at low doses, very low doses, that guaifenesin may work on glial cells. Now, when you said there was no side effects, I can share with you that at the usual doses that I use guaifenesin for pain, lots of side effects. Lots of side effects. Major, sedation, cognitive slowing, fogginess. So I tend not to use that drug much because of the side effect profile. At the lower doses, we may be able to get away with it. But again, it hasn't been well studied in pain at those low doses. Here's the problem, folks. The drug companies are not going to support these drugs because they're all cheap and they're all off-label and they can't make any money on them. And it's in a business. That's what they're there for. And so it's hard to get support to actually study these type of drugs. And that's why, again, we're out there beating the bushes to try to look at them because they do offer some promise. I don't mention NSAIDs because they generally don't work for fibromyalgia. We haven't found that NSAIDs work very well. In some people who have also some arthritic type of components in the joints, NSAIDs can be very, very effective. But in randomized controlled trials, the NSAIDs haven't played out well. Lyrica is the trade name of pregabalin. FDA approved about a year ago, and that's what I was showing, the Lyrica or the pregabalin having benefit for fibromyalgia symptoms. This is in that same category that all the others. It has side effects. The side effects for Lyrica, for pregabalin, tend to be sedation, sometimes a little dizziness, minor amount of weight gain. Most of these are dose-related. Most of these are time limited. In other words, they settle down after you've been on the drug for a period of time. Some people, though, just can't tolerate it and they have to come off or reduce the dose. So we generally think of ruling out a hypothyroid condition, a low thyroid condition, before jumping in and diagnosing somebody with fibromyalgia because hypothyroidism can lead to very similar signs and symptoms that fibromyalgia has. Hypothyroidism can lead to myalgias, which is kind of muscle pain. It can also lead to peripheral neuropathies, the most common being carpal tunnel syndrome with a hypothyroid condition. And so as a general rule, my low-hanging fruit is I always get a thyroid on somebody. I always get also a glucose tolerance test because diabetes, which is running rampant in society, can also lead to these neuropathic pain type conditions and something we don't want to miss. We also then look at other rheumatologic factors and rheumatologic panel to make sure we're not missing something in that category. There's a number of drugs that are in the pipeline to work on different aspects of those pain processing pathways, everything out here from the periphery to the spinal cord up to the central nervous system. I honestly haven't seen anything that looks like a slam dunk cure. The problem with pain, with chronic pain, is that chronic pain is a disease. It's a disease much like any other disease in our society. It's like diabetes, heart disease, lung disease, asthma. When you think about those chronic conditions, we haven't cured a single one. Haven't cured a single one. We do have great ways of managing them so that people can live very highly productive lives. And we're hoping that eventually we'll be able to get to the point where we can have a cure for fibromyalgia and these other central sensitivity syndromes. But we still got a long way to go. We need more research funding. We need more of these clinical trials that are doing investigative work in it. And I think there's a growing interest in this area. There's a condition called myofascial pain syndrome, which should be distinguished from fibromyalgia. Myofascial pain syndrome involves trigger points. What are trigger points? You all know what those are. Those are those big knots of muscle that you get in your back and your shoulders here that when you press on a trigger point, it not only causes pain where you press on it, but it radiates outwards. And so my wife has got one right about there that if I press on it, pain radiates out over to her shoulder and down, and it's this big knot of tissue, big knot of muscle. And we'll go in and we can inject those. I don't do this on my wife, but I do this on patients. We inject those with local anesthetic, not to numb the area up, but it causes relaxation of that. But myofascial pain syndrome tends to be localized. They're regional. So it's not whole, widespread bodily pain that fibromyalgia is. Fibromyalgia also has the tender points. In other words, when you press on those areas, the pain tends to stay there. It doesn't radiate outwards. And so those are the distinctions between myofascial pain syndrome and fibromyalgia. So two areas of that. One is that there does appear to be a hereditable component to this, and they're looking at this using twin studies. So that's how you go about, you find twins, and you look at the conditions that they share in common and the ones that are different and the factors that are passed down, the genes that are passed down through the family. And they're finding that there is a high preponderance of heredity playing a role. The other thing that we're finding is that the genes themselves are playing a role in fibromyalgia. And it may not be causing fibromyalgia, but it may be setting us up for it. In other words, let me give you an example. I mentioned this COMT gene, COMT. This is a gene that's involved with breaking down our catecholamines, the chemicals that are involved in our fight or flight response. And it turns out that this gene at a certain location, it's at the 158th location, it has a substitution for one amino acid, valine for methionine. Valine for methionine. And it's a very common, it's called a single nucleotide polymorphism, which basically means it's a substitution for that amino acid in that gene. And it's very common in society. And it turns out that with this genetic change that we all have, it's all very common, that it helps determine our sensitivity to pain. And it turns out that if you've got the Val-Val combination, you're very, very tough. You can tolerate a lot of a stimulus. If you're the methionine version, you have much more sensitivity to a noxious stimulus. And this was thought to play a role in society to serve as a survival basis, because it was these Val-Val folks, these are the people you sent off in wartime to fight your battles. These are the warriors. And it was the Met people. These tend to be the more sensitive people. These were your thinkers. They were a little bit more emotionally in tune with things. And these were the warriors. And so it was an advantage to us in having a combination of these people. It turns out this COMT has also been associated with a variety of mood disturbances, general anxiety disorders, depression, the same type of thing we see, and it may play a role in predisposition towards fibromyalgia. It's not that you come out of the womb with this genetic variant and you're going to get fibromyalgia, but if you get an insult, you get in an automobile accident, you get a viral syndrome, you are more likely then to get fibromyalgia as a consequence of having that genetic variant. Is that making sense? Unfortunately, we can't choose our parents. So we've got the cards that we were dealt. What we're finding in chronic pain is that there is a hereditable component to this. There is heredity that's involved. It is passed along through our parents, but there's a large environmental component too. And it may go back all the way to when we were children. It may get to how we were raised as children and how we were taught to deal with a physical insult or a painful insult. And we're now beginning to learn that these memories, that these preconditionings play a significant role in how we deal with pain later on in life. And so all of this plays a significant role. So we can't choose our parents, but we can work on changing some of the way we approach pain and some of our belief systems and some of our fear. I spend a huge amount of time. One of the biggest things that I deal with our patients is fear of what's going on and helping them to get through that and understand that, it is real pain. It's real pain, but these are the things we need to do to help you to get better. And even though it's causing you more pain, to do the exercises, it will ultimately help you. That's an extraordinarily individual question and set of circumstances. And so it's a huge spectrum that we see. It's this bell-shaped curve. We see some patients that almost get complete resolution of their symptoms, go back as if they've never had it. And we get others that, quite frankly, are treatment resistant and very little works for them. The vast majority of people can expect, at the very least, a significant improvement in quality of life, physical functioning, improvement in mood, improvement in sleep. They may not get complete resolution of their pain. It may not just all go away, but they'll often see a significant reduction in it with appropriate therapy. This is one of the things, by the way, this is one of the things that we're trying to drive the field toward. It's this concept of personalized pain medicine. Right now, I get the sense there's a number of you in the audience who may have fibromyalgia or have loved ones who do. And ask yourself, how many physicians have you seen for this condition? How many treatments have you been through for this condition? What we're trying to do is to be able to characterize an individual person, their genetic profile, the individual neurophysiologic things that make them unique, and the individual condition, fibromyalgia or low back pain that they have or migraines. Bundle that all together into a nice predictive model so that we can say that you will respond to this treatment with a high degree of confidence. We are not there. That's where we're trying at Stanford. We're trying to get there, and we hope it will be there someday, so that I can come back sometime down the road and I can answer that question for you specifically or one of your loved ones, how much relief you can expect to have. That has been the case. And we see that also with these other central sensitivity syndromes also, such that at baseline it appears that, and here's a little conjecture on my part, it appears that the central nervous system has some degree of memory, and it is wound up, and it is waiting, in the event that there is another insult, and it flares up again. And it occurs, and I think for those of you who have fibromyalgia, you're probably experiencing that. You go through, periods of time where you're doing great, and then you get flares of it. And then, hopefully it settles down, becomes quiescent, and you go back to business as usual. And that's the frustrating part of it, is sometimes you can't pinpoint exactly when it occurs. And there may be some degree of a delay. We see that some of these changes in the nervous system take some time to develop. And so it may be something that you forgot. I've got this huge bruise on my ankle and a scab there. My wife was saying, how'd you do that? I said, I have no idea. I can't remember. I have no idea. I must have done something. And that's the problem. We have these little bumps and these injuries all throughout life, and we don't pay attention to it. And there may be some delay in when the onset comes back. I'll share with you, what was mentioned is I have a PhD. My PhD is in electrical engineering. And you could not have come across a guy more linear and kind of in the box thinking than me when I was in medical school. And if somebody had told me that acupuncture was improving their fibromyalgia, I would have said, you need to get your head examined. It's all placebo. It's all just in your head. And, I've been now in the business long enough to keep a very open mind to just about everything. I send patients off to acupuncture. I do see that it works for many patients. We're studying it at Stanford. Don't understand entirely how it works. We believe that there is a component of placebo, but we also believe that there's another component that we don't understand involving manipulation of the central nervous system that's playing a role in it. And my feeling is that as long as a patient can afford it, because it's expensive, it's often out of pocket, and as long as it leads to sustainable or durable benefit, then I'm all in favor of it, and I'm happy to write that prescription for it. It's when you're having to go back for it every other day, forever. That's when I say, time out, let's not go there. That's just palliating things. That's like getting a massage every day. Who doesn't like that? But I'm glad to hear that, I like to hear the success stories. If you're talking about chemical sensitivities, again, that's under this rubric, this umbrella of central sensitivity syndromes, in which we see a lot of overlap. You'll find a lot of patients with interstitial cystitis with fibromyalgia, a lot of people with interstitial cystitis with irritable bowel syndrome, and vice versa. So, and again, we believe that there's something that the women's nervous system is wired differently than men's. And we're still trying to understand that. That's why we need more research into these gender issues. The Center for Integrative Medicine, they do a great job at Stanford. They involve things like biofeedback, hypnosis, some of these mind-body connections that can be very acupuncture, things that can be very effective for these chronic pain conditions. And then, obviously at Stanford Pain Center, we're here to help you. If you have questions or if you'd like us to see you, we're happy to do so. Hey, listen, you've been wonderful. Thank you for coming out again on a school night. And we'll let you get out of here, and thank you again.
Think Forward. Think Research Channel.